Good morning, everybody. There was no sound because we hadn't started yet for everyone online, but thank you for letting us know. So welcome to this morning's academic meeting. It's an ethics talk, so everyone is excitedly on board to get your last ethics points before the 31st of March, and the HPCSA hunts you and your families down. But we're very excited to have Francois, who's well known in our department, Mark Heywood and Sasha Stevenson join us for this ethics talk. So there's lots going on with HIV funding, lots going on with PEPFAR and USAID, which I'm not going to talk about because our panel will. But just to introduce our speakers, so Professor Venter is division head of Azincha here at WITS. He's, as I said, well known in our department and across the country, having led multiple ARV treatment optimization studies. He has an active interest in public sector access to HIV services. Mark Heywood is, I think, also a bit of a household name in the country. He's a health, social justice, and human rights activist and writer who co-founded the Treatment Action Campaign and Section 27 and has been, in his words, active on these issues for far too long. He's also a senior researcher at the Nelson Mandela School of Public Governance at UCT, and he's recently founded two new organizations, the Justice and Activism Hub and the Union Against Hunger. And then Sasha Stevenson is a human rights lawyer and the executive director of Section 27, which is a public interest law organization in Joburg. She holds bachelor's, honors, and law degrees from Rhodes University and an LLM from the University of Cambridge. And she's been working for over a decade to secure systems change that realizes health and food rights, including through representing the families of mental health care users who died after their disastrous deinstitutionalization from life at Eswatini. So I think all of our speakers have in some way touched our lives and touched our training and what we do in medicine. But I'm going to stop talking now because you don't want to hear from me. You want to hear from Francois, and I'll hand over to you.
Thanks very much, and thanks for coming for probably the most depressing lecture of the year. So yeah, I don't care whether you're a radiologist in the basement or some or where you work. This is going to touch you, and I think lots of people. I've got a line here that the reason you don't think about AIDS anymore and HIV is because the system's working, and the system's about to stop working. And I think that's what I want to explain why it stopped working. And I've been giving a variant of this lecture across the world in the last 2 weeks, and it's been quite difficult because it's not just PEPFAR that's collapsed. A whole lot of institutions have collapsed. I've never been in a situation where people from Harvard and Yale and Columbia have been asking me for jobs. That's how bad things are in terms of the US at the moment. So just in terms of disclosures, I think the most important thing is my unit doesn't actually get PEPFAR funding or any of these institutions that have now collapsed. I was the head of the PEPFAR of a very large PEPFAR program. It's actually the largest in the world for 5 years, from about 2003 to 2012. So I've been quite heavily in contact with it even when I stopped heading it. And the reason we're here, I think you all know, lots of people have lost their jobs, lots of people, it's affected us in very different ways. Some of you might not have felt it yet, you're about to. Huge number of people I know have lost their jobs and are about to lose their jobs if some of the funding cuts happen, which I think they're almost certainly going to happen. So it's important to remember the funding cuts have gone way beyond PEPFAR. And I actually didn't realize some of this stuff, but entire health systems, Malawi's and Zimbabwe's health system is almost entirely dependent on USAID, and the USAID has almost ceased to exist. Famine and disaster relief programs, a whole lot of feeding schemes have just gone, disappeared. And when people say, oh, no one's died yet, lots of people have died. NIH research, it's almost 70% of South Africa's TB and HIV, in fact, total research budgets. A lot of the research that goes through the South African MRC is going to be affected, but it's going to hit, if the funding cuts start hitting the overall NIH, which we anticipate for South Africa, it's going to hit oncology, it's going to hit cardiovascular medicine, it's going to hit everyone. So it's not just HIV, but it hits everything. Again, USAID funds everything from governance. The Americans give huge amounts of money to childhood vaccines across Africa, not to South Africa, but across elsewhere. But even the CDC advice things, which I rely on heavily for infectious diseases, has been smeared. Like they've removed mentions of many of the vaccines. You can't do anything in mRNA vaccines or anything. So again, that's going to hit oncology, a whole lot of the stuff that we do. So I've had lots of responses to this. Often people who've got good private medical insurance will say to me, it's time we stood on our own 2 feet. You know, Americans shouldn't be blackmailing us like this. And there's a lot of anti-American sentiment or anti-South African experiment sentiment at the moment for some reason. And as always, there's kernels of truth to this. It's actually suited PEPFAR and it's suited the Department of Health to have PEPFAR. They work very well together, but they work completely separately. HIV gets too much money. This needs to be righted. I'll show you why that's probably wrong. The other extremists is like Treasury must just find this money and they must pull it together and they must just fund the PEPFAR program all by itself. And then you get from the Department of Health, we must strengthen the healthcare systems and we must integrate HIV into the system. It must all go back to where it was. And I'll again show you why that's wrong. And then there's the thing, oh, is we going to be okay? Us South Africans, we're resilient. We'll be okay. And we're not going to be okay. So how do we get here? The HIV story, for those, there's some very young looking people here. I guess everyone starts looking young at a certain point. Somebody in this department, in fact, told me treating a year and a half ago that diabetes is hard and treating HIV is easy. And actually, that's true in 2025. You kind of say, here's your tablet, go away and get better. And it really has got down to that. You know, it doesn't matter, you diagnosed, you give them the tablet on the same day, they go away and they get better. And that's the reality of HIV 2025. It's important to remember though, again, when things are working, you don't hear about them. And that's because, you know, HIV in 2003, 2004, when Graham and I were around, was a very different story. We had it was a hell of a lot more complicated than diabetes. We had complicated testing algorithms for just making the diagnosis was hard. You had to do multiple tests, you had to like stage them, you had to like dose them differently in the morning, in the afternoon with different tablets. We had to dose you differently if you're a woman or if you're a man, if you wanted kids. We had to do, if you stopped the therapy, you had to like give them different things. It was a real conjunture. So when people talk about this, this is what we were doing in primary care across the road in Yeovil Clinic. So this is not, it was not as easy as it is now. There was a huge amount of work we had to do to get here. And it was hellishly expensive. It's come right down in cost. So lots of people in FITS were involved in this, but it was bad. And certainly when Graham and I were training, like there were people just upstairs in the admission ward who were just on the floor. We had like 20, 30 deaths a day. It really wasn't, it was not a great time. All the AIDS denialists have come out again and said, oh, it wasn't that bad. It was pretty bad. So it was the commonest cause of death by far. And that has now reverted. And I'll show you just some of the numbers in just a moment. And there's a very young photograph of Mark here, there in the bottom left-hand corner. I couldn't find a young photograph of Sasha because she just doesn't age. But I think what was amazing about the HIV response was it was very activist driven. And often the endocrinologists will tell me what we need is a diabetes activist group. And I think they're right. You know, it seems like that's actually starting to happen because of just the cost of these cardiovascular medicines. But I think what's amazing is all these people have come out of the woodwork again and unretired themselves and have now started to work on a response to all these cuts. And thank goodness they did, because no one else seems to be able to understand what to do. So one of the remarkable things about 2008 when Zuma took over, nobody remembers this particularly fondly, but for me it was like amazing. It was like AIDS suddenly wasn't the problem. Like all the fights we were having with Mbeki just disappeared overnight. And at the moment, we've got about 6 million South Africans on world-class therapy. Honestly, the stuff we get in the state sector, in the private sector, is very similar to the stuff you'll get in Melbourne and you'll get in DC. So what was PEPFAR? And PEPFAR paid particularly for all of this to happen, for these experiences, as we learned, and had to go from that terrible time in 2004. So it came about in 2003 by a very conservative Republican president. He doesn't sound particularly conservative now, but like he really was very conservative when he came in. And it's been reauthorized. It's one of the few programs that actually was a darling of the Republicans and the Democrats until now. It was implemented in 50 countries, and it was a hell of a lot of money, okay, by anybody's standards, by any metric you can possibly use. And it was the largest commitment to a single disease. And on the back of this, there were a whole lot of other things that were great about it. It taught us a lot about systems and the knock-on effects in oncology, and particularly in diseases like hepatitis. But it was laser-like focused on HIV. And there's often been lots of criticism, like, why aren't you doing stuff in vaccines? Why aren't you doing stuff in hypertension? Why aren't you doing other stuff? And in different countries, it did different things. Like in Malawi, it paid for everything. It paid for the nurse's salary, it paid for the ARVs, it paid for the CD4 counts, it paid for the condoms. In Kenya, it paid for a lot of stuff, not everything. And in South Africa, it paid, I'll show you in a moment, for for very targeted services. So I was involved. Honestly, if you brought my assessment, it brought all the worst and best things of America. It brought this laser-like thing on efficiencies. I remember speaking to one of the, when I was running the program, I remember complaining how difficult it was. And the guys just looked me in the eye and said, I pay you for solutions, not for complaining. And honestly, it's like that. They do that. They say, your target for the week by week, they'll say to you, your target is find 200 people with HIV. And if you can't, we'll give it to somebody else and we'll pay them. And that's how the PEPFAR program works. And that's why it's so efficient. It's like, there's none of this like sitting on your bum waiting for people to sort of wander into the clinic and declare themselves with HIV. You have to go and find them. So this is why it works really, really well. And I think there are real lessons there for diabetes and hypertension, and all these other chronic illnesses that we really battle with because people come in so late. So this was my very first publication from the clinic about 100 meters away with Jeff and with Charles and other people. And we saw these patients were coming in with about 100 cells of about 180 cells. So those of you who are in this room will know that these patients are very, very, very immune deficient. So these patients were very hospital deficient, and we had this massive wave of inpatient care. You guys are still dealing with this because there's just so many people in the ARV program that even the small number fall off, don't take their therapy, they come in very, very sick. But honestly, the wards were just awash with people with very advanced AIDS. And what I was battling with at that stage was this thing with patients with CD4 count 80. No, we just couldn't get it up. So what we started doing was pushing the counselors into the community, into the antenatal queues. We went active case finding. So we started to get people with a higher and higher CD4 count. We also started these key population services. So I ran this big sex worker program around Hillbrow. We sent teams into the brothels. And we also started to simplify the program. We started getting rid of the CD4 count thresholds, pushing it up. And we ran programs where we showed starting ARVs on the same day was safe. So all this like stuff we did over 20 years, all of it using PEPFAR money. And the CD4 count went up and up and up. And as you all know, the village idiot can start therapy at a CD4 count of 400. If you start at a CD4 count of 80, you better have lots of toys in the tertiary hospital. It's a very different story when you're doing that. Antenatal transmission went right down. It's actually quite rare to see pediatric HIV in South Africa. And new infection rates have plummeted. Okay, it's really, we had 500,000 in a year in 2004, and it's down to 130,000. And life expectancy has gone up a decade. It's now not the commonest cause of death. It was until 10 years ago, and now it's like about number 7. So we've done remarkably well in South Africa because of the treatment program. This is all the propaganda, which I'm not going to bore you with, but certainly it saved millions of South African lives. And it wasn't PEPFAR alone. Obviously, it was with Department of Health Resources, but this laser-like focus on the program has really been incredible. And I'm going to show you where the holes come now. So this came out 2 days ago in the Lancet HIV, and it shows you how dependent some of these countries are on PEPFAR. And what's remarkable is how places like Uganda, Zimbabwe, Malawi are dependent on external funding. They do not pay for their own health services. South Africa, on the other hand, does. You can see that you'll hear again this thing about 17% of the HIV program. However, South Africa's prevention program, which includes testing, is entirely dependent on PEPFAR. The South African government does not pay for its testing program. And that's what's happened. There's no more HIV testing happening anywhere. It's entirely collapsed in central Johannesburg. But you can see this, that little red arrow, so I didn't follow it up easily this morning when I was cutting and pasting this in. You can see how heavy we still do pay for the majority of our own health system. So then we had this happen on the 20th of January when Trump came in. And the whole of activists have launched lawsuits against them, very brave group of people. And there have been multiple lawsuits trying to stop this. But Trump has just managed to say, we're going to go forward anyway. And apparently what he's doing is completely illegal. And when you're a dippy little NGO paying for salaries and things in central Joburg, and somebody from Washington says, don't worry, you can continue. It's very scary working in PEPFAR, because if you deviate even a little bit, they hold you accountable. You have to pay that money back. So people have just said, we need something from wet signature to say it's okay to continue with the program. So the services have completely stopped overnight. So across Africa, the impact has been mixed. I was chairing this in San Francisco 2 weeks ago. These are all heads of programs. They were at the big AIDS conference. And it literally was overnight. Everything stopped across they issued the order, and there were just signs on the wall saying this clinic is closed. HIV testing programs across Africa have stopped, where the PEPFAR was supporting all the key population programs. So all the LGBTI, the sex worker, the drug using programs stopped. Botswana, which is again like South Africa, a rich country and pays for most of its program, supply lines, they don't know where their drugs are. The PEPFAR was paying for charting where the drugs were, they just don't know where it was. In Kenya, they had an electronic medical record system. The entire tech team just went home. They were essentially deported. No one knows how to unlock the electronic medical record, so no one knows. They can't get any of the blood results or any of the patient clinical details. Uganda, same thing. All the data systems have collapsed. And these 4 countries, the entire health force was paid for. They just went home. They're all sitting at home, still waiting to be called back. So there's nobody to actually deliver the services. Ministries of Health response has been largely, we've got this, don't worry. This was coming always, we've got this, it's going to be okay. And the head of the Zimbabwe program said to me in San Francisco, I said, what were we going to say? Everyone's going to panic if we said anything else. But my program, the entire health system has collapsed overnight because they were paying for everything. And it's important to understand there's nobody who's going to be able to bail them out because no one's got those kind of pockets. The Americans were paying so much money that there's no donor, maybe the EU, but they're all distracted by war and a whole lot of other things. But low-income countries don't have that kind of money. South Africa has that kind of money, but I'll show you the problem. So these 3 countries, though, largely fund their own program. They're middle-income countries, but they have key aspects supported by PEPFAR. The rest of them are integrating, they say. They're going to send people back to the clinics where they were. In many cases, there's no clinic to send them back to. So these people are probably just going to go home and die of AIDS. So in Uganda, Mozambique, Zim, big chunks of the rest of Africa, we're going to go back to 2001. So modelers, Brooke Nichols, who works at Hero here at Wits, put out this paper almost immediately and put out this website, which comes with updates every hour, tells you how many people are going to die. These modeling papers, as you'd imagine, because of the removal. And as you'd expect, this paper, as I said, came out today. Is this, you can just plot this on top of South Africa. This is what's going to happen. New infections are going to go up. Death rates are going to go up. It's pretty predictable. And it really is unbearable. We were doing modeling in January, which said we could probably break the back of that 130,000. We could get down to 20,000. There's this new drug that was just released at San Francisco 2 weeks ago. It's an intramuscular injection that lasts a year, and we think it gives up to 2 years. I reviewed the paper actually when it was going in, and it really does look like 2 years. It's 100% effective as a prevention tool. I mean, it's a vaccine for all intents and purposes, and you can instead of like contorting yourself around the prevention program, we could just go in and probably vaccinate the high-risk populations, and instead we're back to where we were in 2004. So what did we fund in South Africa? We funded 17% of the budget, as opposed to Mozambique and Uganda. We did not pay for drugs, we did not pay for labs, didn't pay for condoms, we paid for very key areas. We also focused highly on where the patients were, on 27 districts where 78% of the patients. So PEPFAR does this, it goes and finds where the patients are. It doesn't mess around with like rural areas where there are only a handful of people. It finds where the numbers are. And they very laser-like focused on case finding. As I said, this is why we've got a situation where most people have got a CD4 count 400. They don't have TB, they don't have crypto. And they did a lot of TB screening and support. And that's another reason why the TB program for the last 10 years, we've been seeing a fall in the incidence of TB. They also manage the data system. And it's part of the reason you can manage the system. They collected how many people came in, how many people were still on ARVs, who disappeared from the system. They go and hunt them down if they fell out of the system. So loss to follow-up rates were actually very, very low. And they employed 220 technical experts for the Department of Health at the national department to make sure supply lines ran. And then they paid for these key populations. So I ran a sex worker program. I started a trans clinic here in Hillbrow. There's a gay men's clinic in Yeovil. Like across the country, there were these specialist populations. So why should we be scared? I'm almost finished. So now we have no HIV testing across the country. Government says, don't worry, just go to your clinic. We've always done testing, it's fine. As far as I know, you still can't get an HIV test. The key population program, there's still signs up on every single clinic which says we're closed. So again, the Department of Health says, don't worry, you can just go, these people must just go back to the clinics. Having run the sex worker program for like over a decade, I can tell you those sex workers are not going to go and sit in those queues. So again, you can understand from a public health perspective, we ran those things not to be nice to sex workers, but simply because That's the way it's the only way to actually get services for them to cut the chain of transmission. And now we're getting mass reports of stockouts from across the country. And again, the minister says it's fine. It's not actually happening. So we are going to go back to 2004 in the next few months, and we're going to have no TB screening. So it means those few hospital beds you have empty, which I'm sure has been the case for the last 10 years, are going to be filled with crypto and pneumocystis and pneumococcus and all the stuff that Graham and I remember and love from that period. It really is horrendous how quickly this is going to turn around if they don't fix this and fix it fast. There's also no key population program, so all those people who were entering there, we made it nice for them to actually enter, but it was incredibly efficient. There's those prevention programs, we're going to see new infections going up again, and we're going to see a lot more illness there. There's no early warning system. All those major enters have gone home, so the minister's not going to know. So he can continue to be in denial, which he is at the moment. This, Ian Zahn pointed out to me, he said, everyone's going on about the steel industry and how we must bail the steel industry out. We've just lost 24,000 jobs, and PEPFAR is giving us 20 billion rand a year just for PEPFAR. This is not a billion rand that we get from the NIH, and it's not the huge amount of money USAID was giving us for climate change stuff and the governance and everything else. But he says this might actually by itself might tip the country into recession. So it's again something to feel if you weren't depressed enough to begin with. And then there's this, which I did not think about and I've forgotten about, but Lesotho's health program has completely collapsed. And again, the minister was like, we got this, don't worry. They ran out of ARVs a few days ago. So there's a country nearby which I think they're going to be entering on this. Zimbabwe has a health tax, 3% of an AIDS tax, 3% of all payroll and any big financial transactions that go through trusts goes to this money, and ostensibly 50% of it goes to pay ARVs. The head of the Zimbabwe program said in February, that dropped by 30%, which gives you a sense. And when I thought about that, that gives you an indication of how dependent the Zimbabwe economy is dependent on the US government paying for formal salaries. And they're not going to go to Botswana, I'm telling you. They're not going to go to Mozambique, and they're not going to go to Zambia. I know where they're going to go. And when their economy implodes, when this starts happening, we're already on a precipice in terms of xenophobic violence and stuff. You guys have seen better than anyone like what happens here in Hillbrow every time this happens. So again, our neighbors are coming, and again, our government's got this. And there's no plan. Sasha and her friends have tried to signal that this is unacceptable, has repeatedly written to the government to say what's going on. And unfortunately, we're now 8 or 9 weeks into this now, and we still don't know what's going on. So we've got a primary care system that will take care of this. Unfortunately, I don't know. It's definitely not easy. I don't think the government's in a particularly easy position. It's financially strapped, and I know you guys are dealing with all the stuff that Gauteng is dealing with at the moment. And there isn't money available. But the problem is the government has to come up with something to try and mitigate what's coming. Otherwise, the hospitals are going to get swamped. This is like where we were with COVID in the first few weeks. Something needs to be done. It needs to be done urgently. So I think it's a really bad situation. I think I feel terrible for government actually at this point, because I think they're facing kind of a precipice, and I don't have easy solutions for them. But for everybody involved at this stage across the world, but certainly for South Africa, this is not a good situation to be in, and to say the least. But I also think that we should be preparing and for this to come, and there are things I think could be done a little bit smarter and better. There is some signs that PEPFAR Light might be coming for the other countries. I don't think it's going to be coming back for us in a hurry, and I don't actually think it should be. I think that Malawi and places like that should be prioritized. But the world, as you can hear, is probably never going to be the same. So I think I'll leave it there in the hand to the panel.
Thanks, Francois. Mark, Sasha, you want to come join us up front here? Sasha going first. Yeah. I think we can do it together as a conversation. Yeah. Okay. So thanks, Francois. That was not even depressing at all. Thank you. I'm going to be less sad about the potholes on the way home, because I can drive around those. But no, I think we can see the impact. You've highlighted it. I'm going to unmute the other microphone quickly. Right. So sorry, if you're online, you might hear a bit of an echo because we have two microphones going. But I'm going to start off then asking Sasha. I'm a big fan of you and your work, so I'm going to admit my fanboy here. Because about 2 years ago, when the government was trying to make antenatal patients pay for attending the antenatal clinic, Section 27 stepped in and what the Constitution says. We know that the government is xenophobic. I'm going to put it out there. I might get in trouble for saying this, but don't care. Now we're going to have a whole bunch of patients from Zim, Lesotho, Mozambique coming in to get care, but they're not allowed to access care because you have to pay 450 Rand every time you come and fill your script. What impact's that going to have? And from the legal perspective, what does that have?
Yeah, so we're at a really, I mean, obviously everything's very depressing, as Francois says, and I think it's going to be a bit more complicated in some respects on the migrant patients front. And that's partly because of NHI, weirdly, and the move towards NHI, and because what NHI Act now says is that really it's only South Africans who are entitled to most services, and others are entitled to emergency medical treatment. The provision for pregnant women and young children is no longer there. The primary health care for people who aren't South Africans is out. So of course, you know, NHI Act hasn't been promulgated, and so it doesn't apply currently. But I do think that there's a risk of this precipitating further medical xenophobia coming from the ministry, and potentially moving to kind of implement those access provisions under NHI in response to this, which of course we all know is a terrible idea for public health, particularly when it comes to HIV and TB treatment. But I think it's a real risk, and you know, the law is helpful in some respects because of the requirement in the Constitution that there must be progressive realization, and progressive realization means things need to get better, and certainly that then they shouldn't get worse. And so there is some potential there, but it's a complicated one, and I think the likely influx of migrant patients needing ARV treatment might push us in the wrong direction, and towards a more restrictive NHI, which will then start off another bunch of fights, as if there weren't enough fights on NHI already.
I mean, then, Mark, from a social justice point of view, I mean, how do we get these patients? How do we help with these migrant patients, getting them into the clinics, and what is the step to go into Hillbrow to, you know, help these patients and get HIV care to them from your side?
Well, I think, you know, that there has to be a revival of HIV and health activism. And that revival of activism has to embrace healthcare workers like yourselves in this room, in raising both the alarm, because I don't think many people will have heard Francois' type of presentation. As Francois said, you know, government is trying to, we've got this, to downplay it, etc., which is completely wrong. But also trying to get to the solutions. You know, it was through a collaboration between activists and people like yourselves that we have made the huge advances that we made in South Africa and the world. And I think that's not often understood. You know, it was the banging on the doors by activists that got HIV taken seriously. Once HIV was taken seriously, resources began to flow into HIV, which meant that clinicians, researchers, etc., could do much more than they were able to do prior to that. And we have to think how we can revive that. You know, even the PEPFAR fund wouldn't exist if it wasn't just that George Bush woke up one day and had a, oh, I want to be good to the world moment. It was that activists from the United States, ACT UP and so on in particular, were saying to the United States government, this is a global pandemic, it needs a global response, and the USA can play some sort of a response in that. The same is the case with the Global Fund on HIV, TB, and malaria, which is another massive source of funding all over the world. And, you know, Francois didn't touch on this yet, but it seems there's a probability that when it comes to the replenishment of the Global Fund, in a month or so, the US is going to cut its funding to the Global Fund as well. So we'll have lost PEPFAR, we'll have lost NIH, and we'll lose the Global Fund as well. So we need to, in a sense, we need to get our heads back together again. Let me just finish answering your question by this. I mean, it was literally almost in this room that 30 years ago, we started working together as health activists and researchers and clinicians. It was Human Rights Day last Friday, 21st of March. 26 years ago to that day, we held a demonstration outside the gates of Chris Hani Baragwanath Hospital with Glenda Gray and James McIntyre and a few other people saying that we demand action. At that point, it was limited to preventing mother-to-child HIV transmission, which was the most obvious and the most immediate intervention that could make a difference. But from there, we went forward together, and we're going to have to do that. The last thing I would say, though, is that we can't now, we need to get that laser focus on HIV and TB, but we can't separate these issues from the crisis of the management of the healthcare system as a whole. So how do we deal with the problem broadly and intensively at the same time? I mean, I've just written an article which will come out next week, trying to persuade government, look, there's a connection between health and economy. And so instead of being kind of resentful about health funding, recognize that if you fund the healthcare system as a whole properly, there will be economic benefits, productivity, growth in GDP, etc. So we need to learn how to advance those arguments again. You know, we massively underspend on health across the board. I don't think you may be going to come to this question, but you know, we're not the authors of our own misery. It's not a question of we should be funding all of this ourselves. Malawi should be funding all of itself. Zimbabwe, Lesotho, etc. It's not either or. There is a global duty on developed nations like the United States to put resources into global health threats consonant with the size of their resources and the size of their economies. But there's also a duty on countries like our own to spend properly and efficiently. And when it comes to South Africa, you know, we talk about we're spending 8.5% of GDP on health. Well, we're not. We're spending about 4%. Of half of that. Half of it is what the private sector is spending or what medical aid members, etc. We're actually dramatically underfunding health, and we're hiding that fact behind the overall picture. So this is really a wake-up call. It's a call to activism, to getting these conversations again. Otherwise, we're going to be flooded.
Can I maybe jump onto that? Sorry, just on the underfunding of health, which is certainly a big part of the problem. You know, in this budget, we've seen an increase in the allocation to health if the budget goes through. And of course, the increase of allocation to health, amongst other things, has also come with a VAT increase. So the same people who are benefiting here are being disadvantaged here. But a big part of the problem is that once the budget gets allocated, we don't spend it. So this province sent a huge amount of infrastructure spending back to Treasury last year. I mean, you look at the hospitals and you look at the clinics and you think, it's not the case that our infrastructure is great, but the province is sending the money back. In a court judgment we got yesterday about the radiation oncology crisis centered on this hospital, where we negotiated with National Health and National Treasury and Provincial Treasury to give 784 million rand to Gauteng Health in order to do radiation oncology services, to outsource some and to capacitate the hospital. That money has not been spent, and 250 million rand of it got sent back to Treasury last year because this province said it couldn't spend that money. Couldn't spend 250 million rand to potentially save the lives of 3,000 people who have been on the backlog list for years now and who are going through surgery and are going through chemo. You know, we've sent back money, as I say, for infrastructure. We've sent back money from a lot of our conditional grants. So not only are we now not getting foreign funding, and it's not just US, it's other nations that are now turning inward because Europe is seeing it having to protect itself because NATO is no longer reliable. We're seeing we're not allocating enough money to help, and then we can't even spend the money we have. And that's really a big risk here, because as Francois said, the HIV program was a strength within a deteriorating system, as you all know, as you're all seeing. And there are things that can be done right now to strengthen that system, so that as the kind of pillar of strength weakens with this destruction of the funding model, at least the rest of the system can hold. But we need a lot more political effort, particularly in this province, to get that right. And that political effort is going to, again, as Mark says, require a lot of joint activism, I think, from everybody who's affected. And as he says, maybe this is something of a wake-up call for all of us.
I'm going to come back to some points and questions, what you said. I just want to grab and give a question.
I can only speak from, you know, we've been killing a nephrologist. We've not been providing dialysis. We've had no increase in dialysis since 1994. Not one extra slot. Like I said, it was a terrible event. Unfortunately, we send probably 150 patients home to die every year from this hospital alone, let alone all the others. And the one thing that surprised me is the cost that we have to pay for a machine, fluid, when I have colleagues in India who tell me we can do dialysis for $20.
Yeah.
And here we're doing it equivalent $200.
Yeah.
Now, the world is shifting, and you know, I guess we're being punished for looking more east and west. It seems to be what's at play here. But are there not opportunities to firstly deregulate? Why is it so difficult for me to say, well, why can't I bring a machine from India? SAPRA says no, this one says no. Is there not opportunities to deregulate and then cut costs? And do we not need different partners? The Indian economy is massive. Okay, look, they have their own problems, etc. You know, we've had requests like Chinese company, we want to bring machines, but unfortunately, maybe there's pressure from the big three, the European, the US company. Oh no, we don't want, we don't want Toyota dialysis machines. We want, must be the German machine. So why can't I look for cheap? And maybe this is what we should be doing as well, is saying, well, it looks like we're in for 5 years of, I don't know what to call it, an adventure of notes. But it looks like we're not going to be friends anymore. It looks like there's this absolute, I don't know, it's psychopathy, I guess. But can't our government start saying, well, let's talk properly to our partners. Let's get cheaper equipment, cheaper tests. Because I think, to be honest, the cost that Europe and the US are, I think that they're too much. I can't see that they're justified how much they want us to pay for things that we need. Just maybe a shift. Say, well, okay, you've divorced us. All right, fine. I'll find a younger, better one.
Just before you answer, I'm not going to be able to give Graham's nuances to the people online, but essentially the question and the comment is, do we not, getting funding from the US and Europe comes with getting equipment and testing things from the US and Europe, and should we not be looking towards the East, India, China, we can get things for cheaper and deregulate sort of the health sector to get cheaper tests and cheaper things in as a solution? That doesn't cover exactly the gist of Graham's question, but you'll get it.
You want to go first?
Okay,
Yeah,
sure.
I'll take.
Yeah, so I think those things are likely to start happening, right? You know, we've got a real strength in SAPRA, in that it does hold us to high standards. We've got a strength there. We've got weaknesses elsewhere in that, for example, our Patents Act, which we've been trying to amend for years to make it more public health friendly, to stop unnecessarily protecting patents on and which are monopolies on the most expensive drugs, and making it more difficult for us to access medicines. We've been pushing to amend that act for years, and there is no appetite, and that's, you know, it's partly the fault of health, but it mostly sits within Department of Trade, Industry and Competition, because there's this kind of trade and health balancing act, but the result is that we're punishing ourselves by allowing these monopolies to continue to exist, and by not being able to access products that are drugs and products that are less expensive and that work better for us. And I think that this, you know, as Francois said, we're going to need to change the way we do some things, and stop not kowtowing to these kind of monopolies might be one way of doing that, while also ensuring that we continue to have the kind of high regulatory standards, because that is also a feature of the South African health system, and we don't want to. I don't think we want to mess with that. So I think there's a law reform potential here, and we're going to need to push it hard, and government is going to need to get a bit braver, which is not a strength at the moment, when it comes to standing up to some of these big pharmaceutical and other monopolies.
If I agree with what Sasha said, I would just add one other dimension, which is, I think what prevents what Sasha has just said could be done, and could be done quite quickly and expeditiously, is political will and commitment to health, and understanding, as I said, of the connection between health and societal well-being, and health and the economy. Because to do what Sasha suggested is not that complex, but you need a degree of competence in government to do it. And the problem at the moment is that our National Department of Health lacks competence. I'll be blunt about it. It's been hollowed out, and it's full of rhetoric, which is easy to do, and very little action. This requires action. It would require the minister to go to the Minister of Trade and Industry and say, why don't we go together to the cabinet and prioritize sorting this out? The PEPFAR crisis has accelerated the need to do all of this. And whilst we're doing it, why don't we also sort out issues around availability of medical technology and the cost of medical technology, and let's send a delegation to India or China and see what the possibilities are there. But none of that is happening. So all we're getting is a lot of hot air. And the other and it's borne out by the fact that, you know, when government decides it wants to fix something, as we've seen recently with business and government are busy fixing Eskom. They're busy fixing Transnet. They're bringing the best minds. They're cutting the red tape away, but they're not doing it for health. And the problem is worse that, you know, in a province like this, and again, I can afford to be blunt, your health department is completely corrupted. And a completely corrupted health department's primary interest is not working with us, all of us, to solve the manifest problems that have been created by the loss of PEPFAR money in this province. Their eyes are on what they can steal and what they can position for tender benefits, etc. And we've got to sort that out. But the thing is, either we complain like we're doing now indefinitely and nothing gets better, or I'm afraid to say you're all busy, obviously, and under massive stress as healthcare professionals, but we have to find a way to find a voice on these issues and to sustain a voice. So once off activity is not good enough because governments have learned how to deal with, okay, there's a protest, we'll send somebody to pick up a memo, they'll go away next week. You've got to be tenacious. I mean, the case Sasha's just told you about, the cancer care, you know, Sasha has been running that since 2020, I think, on behalf of the Cancer Alliance. The Life as a Demeni case, you know, we picked it up in 2016. We got outcomes. We've got to keep going together. But if we believe in our health, if we believe in our patients, if we believe in health systems and we intend to stay in this country, then we don't have much choice other than to fix it.
I think just on that note, we're all slagging off the Department of Health, rightfully so. We did invite we sent an invitation to the Deputy Director General of HIV, TB, Women's Scheme, so very long title. But HIV is in there. We heard nothing back from him. And then we sent an invite to Professor Chris, who's running NHI, and we got an email back saying he can't make it and no one in his department can because of the G20 something on today. So, you know, we definitely wanted the DOH here to be able to respond and say what they're doing about this, but this is classic. And I was saying to Sasha as we walked in, we tried to do these town hall meetings last year, which a lot of you came to, and they were just, we have obviously stopped doing them because they were completely useless to try and get any feedback from management within the hospital itself. So DOH has been given an opportunity to be part of this, but they declined or ignored the invitation. Are there any more questions in the room? Wow.
Yeah, I mean, you guys have obviously experience, and particularly Mark Francois from like the last 30 years, similar issues and trying to get solutions. I mean, for us as people on the ground, how do we get to the point of tipping over some sort of response? I mean, Francois as well, in terms of trying to gather some sort of data early on and in a way that we can see early warning signs that can push some sort of action. I think you showed some of the kind of dashboards, but I mean, we need to be trying to think of how we can gather some sort of information that things that are early markers of the impending disaster at our borders or within our healthcare system that might be more persuasive than just making a noise.
Yeah. Can I just quickly answer that? Please do exactly that. Gather the evidence and find ways of channeling the evidence to organizations like Section 27, who can act on it and who can get it into the public domain and try and build pressure on government to act. I also think, as I was listening to Francois, I was thinking Francois needs to do this presentation to the business community. You know, I had a meeting with Kulekane Mate, the CEO of Business Unity South Africa, to talk about the health situation a few days ago. And I think you need to present it to Business Unity South Africa because business is also another pressure point that government, certainly the president, listens to at the moment. So we have to approach a number of angles. One of the problems is that, and Francois didn't mention this, I mean, one of the casualties of the PEPFAR funding is also activism. The Treatment Action Campaign, which has driven the response in South Africa, has had its largest program, which is community-led clinic monitoring, cut completely, stopped, defunded. And that program, which was a 50 million rand a year program monitoring 500 clinics across the country and collecting data in a very scientific, effective, efficient way and presenting that data, cross-subsidized TAC's kind of main organization that allowed TAC to continue to be outspoken on these issues. So I'm on the board of directors of TAC. At the moment, we're scrambling, can we even save TAC, frankly, at this moment in time? So what you're suggesting is absolutely essential.
So I know this because whether or not you're allowed to dialogue by the state and whether or not our criteria are okay or not is something I carry on about. But so our NHPRL, which is our basically anyone's entitled to treatment. It's just NHPRL says if you're of a certain category or whatever, you have to pay. The same regulation states that if you're a member of a SADC state, you're entitled to free healthcare in South Africa.
Yep.
It's in the law.
Yep.
It's right there. Yeah. So you cannot actually technically refuse patients from SADC. They have the same rights as citizens. I mean, we've written to, you know, as I say, I'm on the ministerial committee for dialysis and transplant, but we've asked the government to please try and clarify what this has said, and you're absolutely right that anybody who puts their head out off, just like it, they absolutely will not look at that law or changing those regulations at all.
Yeah.
Because the fact of the matter is that SADC members are entitled to free healthcare in South Africa, any SADC country. So I can go to some, you know, fair enough, you know. But, so there's this weird dichotomy that, so we're going to be refusing people in Hillbrow. It's not actually legal.
No, it's not.
The SADC rules are quite clear.
Yeah, it is. I mean, we've got a SADC protocol on health that says we must all treat each other like, you know, a SADC citizen in South Africa must be treated like a South African citizen. So they must be means tested in the same way that South Africans are, and they are entitled to services. We've also tried. We may have to litigate about it. But the movement is definitely in the other direction through NHI. And the neighboring countries don't reciprocate, and so that makes it a politically complicated thing. But I think the point that you made about sticking your head up is an important one, and it's what has been a strength of the clinician-driven HIV activism has been in South Africa. That strength has been strength in numbers, the banding together effect, and not banding together just as clinicians, but banding together with activists and lawyers. That's what worked. And it was tough for Ashraf and Haroon and Francois and the other people who stuck their head up in the early days. But that kind of joint action, I think, was really helpful. And there is, as Mark says, there's a real impact on civil society of all of this, and so there's weakening there, and we're trying our damnedest to kind of hold the line, and we're trying our damnedest to do things like maintain the Stop Stockouts project, which we started in 2013 when there were widespread ARV stockouts, and through that work, the department improved its stock management. And so the result is that until now, there's been very little ARV stockouts. There've been other stockouts. The most out-of-stock medication is contraceptives every year, which says quite a lot about prioritization, but it's still not a lot of stockouts. Now we're going to be seeing more. We're already seeing PrEP stockouts and ARV stockouts. We're holding that so that the reports can come in. And one of the things that clinicians can certainly do is report stockouts. The other thing that you can do is report the other things that you're seeing to people like us, so that we can start trying to aggregate this information, collect it and use it in a way that isn't scary and dangerous and doesn't require you to stick your head up too much. That being said, we can't pretend we know this information from nowhere. And so it is important that clinicians are able to stand up for some of what they say, and some of that requires, you know, internal organization through the various structures that you have. Sorry, Francois, you might want to add.
No, I think it is scary. One thing I have appreciated, having crisscrossed the world of what's happening in the States at the moment, is how much I appreciate that.
There's freedom of speech, obviously, like, you know, and also coming from the rest of Africa, people are terrified of speaking out. Like, they could not get anyone to speak about the PEPFAR shutdowns. Even that panel that was up there, they were scared to be quoted or pulled. So, you know, PEPFAR pulled out and defunded us. Like, you should be able to say that's what happened. There was nothing politically charged about it, but people just were very, very scared to be quoted in any shape or form. I'm aware of people who were deported from Malawi, for instance, for speaking out about bad decisions PEPFAR had made about how they ran their program and stuff. There were decisions they made because the health system was so dependent on the funding. So you do sort of appreciate being a South African and being able to, like, I rip into government every other day. And, it doesn't, I don't walk around terrified I'm going to be pulled off the streets like Americans are at the moment, and I think that it's something you do need to think about and appreciate and use that space as much as you can. You asked about things we can do. I think that sometimes we overthink the data. I've asked my staff, just go in to the clinic here in Yeovil and say, can I have an HIV test? And if you can't get that, that means the program's not working. And another thing I say is go and ask for PrEP. If you can't get that, the program's falling apart. Now, know that it's not working because they fund all of those programs. That's all we need to know. Like, honestly, it means, Central Joburg is, there's so many people living there. We need an HIV test, and we're not going to face anything here at this hospital. So I can say that you are going to see it. I think you're going to see a spike in the crypto cases. We've been trying to get the NHS database, for instance, because we're going to see it rising there. We're going to see the CD4 count numbers go down. We're going to see the crypto, cases going up that are being required and pulled. Yeah, we know how these things work. We're going to see this, and it's going to probably start towards the end of the year. To my mind, the people who fall off the program, the people who will be caught with this, there's a fair number of people still coming in with C for count below 200. Those people are going to come in just 20, 30 cells lower they can from there. So there are sort of these central sites that we can use. But as I said, we have to have a government that we can actually talk to. And at the moment, it's like, no, this is fine. We've got this. It was a wake-up call for us that we've got this. And unfortunately, they don't got it. And Mark says that Gauteng particularly, the National Department, there are departments in the National Department are actually very strong, like the Affordable Medicines Department, who you can talk to and say, we need a plan for this. We were busy discussing things like the insulin outages. They were called napping, but they were starting to talk about what they were going to do about it. But those 220 people in the Central Department are gone now. And now, as you were saying, they were hollowed out before, they are totally hollowed out now.
I think for those of us who are younger in the room, we rode on your coattails. Because by the time I started practicing, it was really CD4 of more than 200, and then 350, and then 500, and then test and treat. So we need to learn about activism and what to do, and because we've had it cushy, to be honest. I think we've got time for one more question. Sorry, I'm going to move to the other microphone because it's on my laptop. So it's directly at Francois. Can you comment on future research into HIV, like immunization? Has all US funding for further research into HIV also ended? And I think just on that, for Mark and Sasha, we're talking about actual clinical care and making sure patients have access to clinical care, but the research is what got us to where we are with HIV. Yeah. Maybe Francois, if you want to just comment on that.
So a lot of my stuff, there's new drugs, and it's probably worth another talk. There's an update, but the urgent stuff we're trying to see is, can we decrease the dose of first-line therapy so we can cut the costs even further, and can we simplify therapy? The wave of research that's coming is weekly therapy and long-acting agents and things. So we're still working on that, and trying just to simplify things more and more. And again, the way you guys will see it, certainly those in hospital practice, you just want to see patients coming ill, and that could hopefully be the good side that will come through there. And the lenacapavir prevention stuff is honestly, if you can have an intramuscular injection every 2 years, it really is incredible. That is going to be a game changer. We're not seeing community resistance. I mean, as I said, it's unbearable actually seeing how close we were to actually breaking the back of the epidemic. The modeling we had, we would get down to about 20,000 new cases a year, which, considering the size of the country, becomes renal disease is going to be a much, much, much bigger problem than HIV. It's going to be 10 years time if we've got that. We just need to maintain people on treatment. But this is going to switch the whole thing, the whole equation.
So I think then, Sasha and Mark, to finish it off from your side, what should we do as clinicians? What's our role? Who do we go to? How do we make a noise?
So I think, as others have said, the Department of Health has largely been caught napping and needs a wake-up call, and it's too late when they start seeing the data. We know that they've been caught napping because we've been told there's some Deloitte contract to assess the the impact and where all the PEPFAR money went. There's actually no contract that has been signed, so we don't even know if that Deloitte work is being done. We don't know if there is an assessment anywhere within the Department of Health nationally, let alone at provinces. And as I mentioned, there's all of the budget nightmares in this and other provinces. So we need, there's nothing we can really do to influence the US, but there is a lot that we can do to influence the South African government and push a shifting of priorities and push the, as Mark says, the sort of politicization of health, the political will for health. And I think, as we've said, what that's going to take is more and better alliances between clinicians, patients, and activists. And that's what we're here for, to be part of those alliances and to help you say what you need to say and do it safely and to protect you when you do. So I think that the main thing is banding together, keeping our eyes open and not waiting for the solution to come from outside the country or from national or provincial leadership, because it's going to, as it always does, have to come from the people who are seeing it most.
I think Sasha has said everything that needs to be said.
Great. Well, if there's no further questions, nothing else online, anyone else in person?
Oh, thanks.
Say thank you to Mark, Sasha, and Francois for coming through, giving us this talk and just making us aware. Sorry if everyone's depressed, but it's probably a good thing. It's a good place to start and use this energy and go forward. So thanks everyone. Have a great day. Please scan for your CPD. Thanks everyone online.